It's an honor to invite Professor Dr. Ashraf Hedayet, Asr Aini. He speak about low molecular weight heparin role in VTE management. تفضل دكتور أشرف.
First, I would like to thank the organizing committee for this wonderful meeting and my colleagues for attending this lecture or talk. It's actually the role of this talk is the conflict that is happening now between the different anticoagulants, the parenteral, the oral, new oral anticoagulants, and the vitamin K antagonists. We need to have a stop and know the role of each one in the recent studies in the last 2 years. We are going to speak about the worldwide prevalence of VTE, the mortality of pulmonary embolism, the basic treatment guidelines, and the peculiar aspects of low molecular weight heparins. As we know, the annual incidence of VTE in the United States is 600,000 cases every year, and the number of annual VTE-related deaths 300,000 deaths in the United States every year from DVT pulmonary embolism cases, or estimated 540,000 deaths in Europe from the same problem. So, are we addressing a serious problem? Yes. The mortality from pulmonary embolism, the incidence of pulmonary embolism mortality in the United States is estimated to be 1 case per 100,000 persons per year. Symptomatic DVT occurs in only 20% of the cases, and asymptomatic DVT can occur in 80% of patients can have asymptomatic DVT without noticing. The incidence of pulmonary embolism in the United States, as we said, is 1 case per 100,000 persons per year. Fatal pulmonary embolism. 30% are only discovered that they have pulmonary embolism, and they can be diagnosed and may be saved. But 70% can die from pulmonary embolism and discovered in the post-mortem. Pulmonary embolism occurs 3 to 7 days after the onset of DVT and may be fatal within 1 hour after the onset of the symptoms in 10% of the cases. The diagnosis going clinically unrecognized in most fatal cases. So the basic treatment line is that we have to start rapid initiation of full dose of anticoagulation is essential to decrease the morbidity and mortality. The basic treatment line, how to assess that the patient has a DVT and when to start the regimen for the treatment. There is a score called the Wells score. Gives 1 point for the suspicious clinical signs that you can diagnose that this patient has DVT before doing the investigations. Each symptom from those will take 1 point. So if the patient has 2 points or more, he has a DVT likely. If he has 1 point or less, his DVT is unlikely. The treatment of VTE ranges between pharmacological and non-pharmacological treatment. As regards the non-pharmacological, this is the filter as we know. A lot of people rush to put filters in patients who do not need them. We should start with anticoagulation first, and if this anticoagulation fails, then we start to look for other things like the filters. And we know the indications when to put a filter. Now the pharmacological treatment. The ACCP is the meeting for the chest physicians in the United States. In 2012 and 2016, ACCP recommendations in 2016 updated the same topics of 2012 without changing the position of parenteral anticoagulation. This means that still parenteral anticoagulation has a role. When to start the parenteral anticoagulation, we either have a high clinical suspicion of acute VTE, so we have to start the treatment immediately of the parenteral anticoagulation without waiting for the investigations. If we have an intermediate clinical suspicion, we can wait for 4 hours to have the investigations done. If they do not appear within 4 hours, then we have to start our parenteral anticoagulation. If we have a low clinical suspicion of acute VTE, we can wait for the investigations for 24 hours. If the investigations do not appear within 24 hours, we also have to start the parenteral anticoagulation. What's the choice of the initial anticoagulant regimen in patients with proximal DVT? In patients with acute DVT of the leg, low molecular weight heparin is preferred over intravenous or subcutaneous unfractionated heparin. In distal DVT, also, isolated distal DVT of the leg who are managed with anticoagulation, we recommend using the same anticoagulation for patients with acute proximal DVT. And here are the references are always put down on the slide. At home versus in hospital initial treatment of patients with DVT. In patients with acute DVT of the leg and whose home circumstances are adequate, we recommend initial treatment at home over treatment in hospital with evidence-based 1B. The FDA approved application or indication for enoxaprin in low molecular weight heparins, acute DVT without pulmonary embolism, outpatient treatment is recommended. Acute pulmonary embolism, initial anticoagulation. Initial anticoagulation for patients with acute pulmonary embolism, low molecular weight heparin is preferred over intravenous subcutaneous unfractionated heparin. But if the patient has an acute pulmonary embolism associated with hypotension, who do not have high bleeding risk, they suggest in the meeting that they have systemic administration of thrombolytic therapy. In patients with acute VTE who are treated with anticoagulant therapy, we recommend long-term therapy with grade evidence-based 1B. In VTE with no cancer, treatment for 3 months with no new oral anticoagulants preferred over vitamin K antagonists. In VTE with cancer, also the treatment for 3 months with low molecular weight heparin is preferred over oral anticoagulants. In recurrent VTE, you have to switch to low molecular weight heparin. In an acute pulmonary embolism, low molecular weight heparin is preferred over unfractionated heparin. Factors that may influence which anticoagulant is chosen for the initial and long-term treatment of VTE. In cancer patients, low molecular weight heparin is preferred. If we have patient who refuses to take injections, you can use rivaroxaban or apixaban. If you want a patient to have one daily dose, oral dose, and because he is a negligent, doesn't take the next dose, so we prefer rivaroxaban, indoxaban, and vitamin K antagonists. In case of liver disease, low molecular weight heparin. In case of renal disease, vitamin K antagonists. In case of coronary artery disease, vitamin K antagonists, rivaroxaban, apixaban, and indoxaban. In dyspepsia and history of GIT bleeding, vitamin K antagonists and apixaban. In poor compliant patient or uncooperative patient, vitamin K antagonists are preferred because if a patient misses one dose, if he is taking new oral anticoagulants, he is going to have problems. But vitamin K antagonist stays for some time in the circulation, so it is safer for patients who are not cooperative. Thrombolytic therapy use, we prefer unfractionated heparin infusion. Reversal agent if needed for the patient, then you can use vitamin K antagonist or unfractionated heparin. And in pregnancy, low molecular weight heparin. In the ACCP meeting, they neither encourage or discourage the use of the same anticoagulant for initial and extended therapy. And after the acute phase, they do not put any restriction on using any extended treatment regimen that you like. Duration of anticoagulant use in VTE treatment. If you know the cause for the DVT, in provoked DVT, you can use it for 3 months. In unprovoked, without knowing the cause of DVT, in low or moderate bleeding risk, you can extend therapy for as long as you want, for life maybe. And if the patient has a bleeding risk, you can use it for 3 months only. Superficial vein thrombosis. In patients with superficial thrombophlebitis at least 5 centimeters in length, we suggest the use of prophylactic dose of fondaparinux or low molecular weight heparin for 45 days over not using anything. Acute anticoagulation for patients with upper extremity DVT. In patients with acute upper extremity DVT that involves the axillary or more proximal veins, we suggest low molecular weight heparin or fondaparinux over intravenous unfractionated heparin and over subcutaneous unfractionated heparin. The peculiar aspects of low molecular weight heparins. We know that enoxaprin has the least molecular weight with the longest half-life, the highest bioavailability, the highest anti-10A-to-A ratio versus other low molecular weight heparins. Also, other peculiar aspects for low molecular weight heparins, they have antithrombotic and anti-inflammatory properties. Enoxaprin prevented more thrombus formation compared with deltaparin or placebo. In addition, less vein wall neutrophils and total inflammatory cells were present in the enoxaprin group compared with deltaparin and placebo. Tenzaparin was not tested in this animal model. Enoxaprin proved standardization as initial treatment. The Levine study to compare the use of continuous intravenous standard unfractionated heparin in hospital with the administration of subcutaneous low molecular weight heparin primarily at home, the FDA approved the use of enoxaprin in acute DVT without pulmonary embolism as an outpatient treatment. This is the design of the study that was done to compare using in hospital and at home, and approved about the use of low molecular weight heparins at home. The conclusions from this study was enoxaparin is safe and effective in the home treatment of patients with acute proximal deep vein thrombosis. Enoxaparin administered at home increases the convenience for patients and substantially reduces the cost to the healthcare system. Where does enoxaparin stand after new oral anticoagulants? Enoxaparin as an initial anticoagulant after the era of new oral anticoagulants, its use is unavoidable with all the new oral anticoagulants. In all the studies that were done by these companies, they used the enoxaparin as an initial treatment in their study. Where new oral anticoagulants initiated from the first day, in these studies here, they all were evaluating the role of new oral anticoagulants in their study. They used at least 5 days initial treatment with parenteral low molecular weight heparin. In other studies, 48 hours. And in a third study, 36 hours. And from 70 to 100% of the patients going this study evaluating the new oral anticoagulants, they used the parenteral as an initial treatment. Which patients cannot use the new oral anticoagulants? Patients above 75 years, unstable hemodynamically patient, patients with renal disease, patients who need thrombolysis, patients receiving spinal or epidural anesthesia, patients with inflammatory bowel disease, patients with body weight less than 50 kilograms, patients who need oxygenation and mask or intubation, pregnant women, liver disease, patient who is not cooperative and does not take his medicine regularly, patients who has a coagulopathy. All these patients can have difficulty with going with new oral anticoagulants. Conclusion. Conclusions, there are still many scenarios for the patients with confirmed VTE whom are in urgent need to enoxaparin in spite of the admission of the new oral anticoagulants. Enoxaparin is considered the model of low molecular weight heparins, having the broadest FDA recommendations among low molecular weight heparins for treatment of DVT and or pulmonary embolism, with experience over 30 years on millions of patients. Different patient profiles can take benefit from enoxaparin by easy and established dosing pattern, and initial treatment with enoxaparin reduces bleeding, improve handling and implementation, and facilitate outpatient treatment. Thank you very much.